Good afternoon, all. My topic is on hyperlipidemia. As you all know, lipidemia is nothing but cholesterol, triglycerides, and high density lipoproteins, all these things. Hyperlipidemia and dyslipidemia. There is a difference between hyperlipidemia and dyslipidemia. Hyperlipidemia is nothing but increase in the cholesterol, triglyceride levels like LDL levels and triglycerides. But dyslipidemia, there may be a changes like a high or maybe low. But here my topic is on hyperlipidemia. I want to tell about what happens if increase in the LDL level cholesterol and triglyceride levels. So whenever we take dietary lipids like unsaturated fats or anything, what all the mechanism takes place, how this LDL will form and how this VLDL and chylomicrons will affect. So whenever we take a dietary lipids, in small intestine, nascent chylomicrons will be produced, and in liver, VLDL will be produced. So this chylomicron and the VLDL will enters into the blood capillaries through some mechanism, and this VLDL and chylomicron will be taken up by the adipose tissue through an enzyme called lipoprotein lipase enzyme. This lipoprotein lipase enzyme will be activated by the apolipoprotein 2C. Through this, VLDL and chylomicron will be converted into the free fatty acid. The remaining concentration of VLDL and chylomicron which is present in the blood capillaries, that will form as an ideal, and this is intermediate density lipoprotein. This ideal will be converted to low density lipoprotein. This is low density lipoprotein is a cholesterol, and VLDL and chylomicrons are rich in triglycerides. So this LDL, what are converted from the VLDL, that will be taken up, engulfed by the liver with some receptor which is LDL receptor, and this chylomicron will be converted to remnant chylomicron. This chylomicron will be absorbed, means engulfed by the liver, and it will enters into the liver for further process. But and some more which is remaining LDL, that will be absorbed by the engulfed by the hepatic tissues. So what happens if LDL and VLDL, VLDL and chylomicrons increases? So here is the issues that hyperlipidemia, when increase in the cholesterol, VLDL or LDL levels, there is a type 1, type 2, type 3 and 4 processes are there. In type 1, chylomicronemia. This is nothing but increase in the chylomicrons. How it increases in the chylomicrons, whenever we are taking the dietary lipids, that will absorb by the that will enter into the blood capillaries. When they enter into the blood capillary, that has to be absorbed by the adipose tissue. When there is a lack of lipoprotein lipase enzyme, and so that it couldn't able to absorb much. So what happens in blood capillary, these chylomicrons will get increases. So because of that, increase in the chylomicron in the blood vessels. And type 2A is a hypercholesterolemia. Cholesterolemia is nothing but increased in the LDL. Whenever this chylomicrons and VLDL, when enters into the blood capillaries, when it is not absorbed by the adipose tissue or peripheral tissues, this LDL will get increases. When there is a LDL increases, if there is a deficiency of LDL receptor in the liver or in the extrahepatic tissue, this LDL will be remains in the blood capillary, so that cholesterol level will get increase in the LDL level. That will affect the coronary arteries by forming the atherosclerotic plaques and all. And type 2B is combined and mixed of hyperlipidemia. Hyperlipidemia is nothing but both VLDL and LDL. VLDL is nothing but is rich in triglycerides, and LDL is rich in cholesterol. So if the both are increased, then hyperlipidemia can occur. Type 3 is dysbeta lipoproteinemia. That is nothing but increased in the level of IDL. And type 4 is a hypertriglyceridemia, when there is an increase in the VLDL level in the bloodstream and it is not able to absorb by the adipose tissue. That can be leads to the increase in the VLDL to the LDL level. So that is hypertriglyceridemia. Triglyceride level increases and may cause the atherosclerotic plaques and coronary heart disease can occur. And type 4 is a mixed hypertriglyceridemia, is nothing but mixed of both chylomicron and VLDL. They both are rich in triglycerides. If it is not absorbed and it is remaining in the bloodstream, so that both the concentration will get increased in the bloodstream, so that they may cause plaques, atherosclerotic plaque, and may cause coronary heart diseases. And now our aim is to reduce those cholesterol and triglycerides and increase the high density lipoprotein, which is good and which can destroy this cholesterol and triglycerides. So first is primary prevention. I have taken this guidelines from the ACC AHA guidelines. Here first primary prevention is according to the age wise. According to age wise, age between 0 to 19 years, if there is increase in the cholesterol, there may be changes in the lifestyle because of fatty foods and anything like that, and overweight of kids like that. If they check for any lipid panels or anything, if they are getting increased in the LDL level or VLDL level like triglyceride, they have to go with statins. If the patient age between 20 to 39, if there is a lifestyle is changed, so we have to suggest them for the lifestyle, good lifestyle, reduce to take the saturated fatty acids, and we have to consider the risk factors also. When we are going for statins, we have to consider risk factors in the age between 20 to 39 also. Here the risk factors are like diabetes, CKD, hypertension, or any inflammatory diseases like rheumatic arthritis or anything like that. We have to consider, and then we start with the very low intensity statins. And age between 40 to 79, we have to, if the patient have diabetes and 10 years of atherosclerotic cardiovascular disease risk, we have to assess the percentage. After that, and we have to see the LDL level is between 70 to 190. 70 to 190, and then we have to go for the further treatment. So how we will divide the risk factors? Risk. How you'll find the low risk, moderate risk, high risk and all. So we are going with a low risk, which is less than 5%. How you will consider this person as a low risk, high risk? If the person is low risk, means you will be having zero risk factors. The risk factor, and only the LDL level is increased. Then we have to treat the patient with statins and target the LDL level to minimize less than 30 mg per dl. If the patient is in borderline, like 5 to 7.5%, means that patient is in moderate risk, like borderline risk only. Moderate risk, we have to consider less than 2 risk factors like diabetes or like hypertension, whatever. Less than 2 risk factor, and we have to calculate the 10 years of risk. 10 years of risk, that to be less than 10%. That risk factor will be calculated according to Framingham scale, or those separate scales are there for that. Based on that, we have to find the risk factor, and our target is to reduce the LDL is less than 100 mg per dl. When it is said to be a high risk or intermediate risk, you can find it should be like more than 2 risk factor with 10 years of risk. It's considered like 10 to 20%. And the diabetes, considering if the patient has diabetic and the third or fourth stage of CKD, then the goal is to reduce 100 mg per dl. And very high risk, in very high risk, we will consider all the comorbidities, and we have to consider all the acute coronary syndrome or else cardiovascular disease or peripheral vascular disease. Along with the 10 years of the risk is more than 20%. Then the target of reducing LDL level is less than 70 mg per dl. Even extreme risk, which have all the comorbidities along with more risk, more than 20% of risk. And that may be considering all the CKD, history of premature atherosclerotic cardiovascular disease, and in patient with less than 55 years in male, and in females like less than 65 years. Then the target to reduce LDL level is less than 55 mg per dl. And if this is about the patient who are having atherosclerotic cardiovascular disease already, but who are at low risk and who are at high risk. If the patient is at low risk, not very high risk, then we have to divide according to the age. If the patient is less than or equal to 75 years, and we have to go first with high intensity statins and considering all the comorbidities together. High intensity statins, and the target is to reduce more than 50% of the LDL level. If the patient has more than 75 years and considering all the comorbidities and comorbidities, first we have to go with moderate intensity of statins. If moderate intensity they are not tolerating to that, and can go with high intensity statins. And also you can, if the patient is starting with a high intensity, you can continue with the high intensity statins. And if high intensity statin is given but not tolerated, then you can go with moderate intensity, or else you can add ezetimibe, which is cholesterol absorption inhibitor. And if on statins, but the patient is on high intensity statins, but still the LDL level remains more than 70 mg per dl, then add ezetimibe still. And if the patient is at high risk and considering all the comorbidities, high intensity statins can be given, or else maximum amount of statins can be given. If the patient is on maximum amount of statins and LDL is more, still the LDL is more than 70, then add ezetimibe. And if the patient is not tolerating with the statin along with ezetimibe, go with ezetimibe with the PCSK9 inhibitors. Those are evolocumab, acilocumab will come now. That medications can be added here. You will be knowing that a high intensity, moderate intensity and low intensity statins. High intensity means nothing but increased dose of the medications of the statins. Like atorvastatin, you can give 40 mg to 80 mg, and rosuvastatin 20 to 40 mg when it is high intensity statins. When you come to the moderate intensity, atorvastatin 10 to 20 mg can be given, and rosuva 5 to 10 mg, simvastatin 20 to 40 mg, and lovastatin 40 to 80 mg can be given. Come to the low intensity statin, that is atorvastatin will be given 5 to 10 mg only, and atorva will be given 10 to 20, and rosuva 5 to 10 mg. The main target here is, whenever you are using high intensity statins, the target is to minimize the LDL level more than 50%. When come to moderate, around 30 to 49%, 50% like that. Low intensity statins, if you are using, your target has to be less than 30%. If it is not, you have to add the medications like ezetimibe or PCSK9 or any fibrates, and you can lower the cholesterol level. And what if the triglyceride level is high and cholesterol level is low? Triglyceride shows high, or sometimes triglyceride and LDL levels are high. So if triglyceride levels are high, the normal range of triglyceride is less than 150 mg per dl. So when it is more than that, like the triglyceride level is more than like 150, less than like 200, less than 200, then you can go, first you can give the statins and the lifestyle modification can be done. The main aim is, when the triglyceride and LDL level both are high, first we have to target on the LDL level. So we have to reduce first LDL level and then go with the triglyceride level. So when with that 150 to 200, you can use statins like high intensity or low intensity, moderate we can use, and can reduce it. When the triglyceride level is between 200 to 499, then we have to first try to reduce LDL level with statins. If it is not possible, then go statins with fibrates like fenofibrate or gemfibrozil, or else instead of fibrates, take a niacin. And if triglyceride level is more than 500 mg, first try to reduce the triglyceride level, and you can add statins with fibrates or else niacin. And then the doses of the fibrates are, fenofibrate is around 48 to 145 mg, can be given once daily, and gemfibrozil is around 200 mg, can divide a dose with BD like 600 mg can be given BD, and niacin will come in 250 mg. That can be given twice or else once based on the LDL and the triglyceride levels. And contraindicated is statin should not be given in the pregnancy, but I didn't find a particular reason for that. And estomib dose is 10 mg, that will be given once daily. Now I have a question that I have a case. With that case, just identify what patient is suffering with, whether it is low risk or high risk, moderate risk. With that, take this scale, and if the patient is suffering with low risk, moderate risk, and high risk, what is your target of reducing the LDL level? Okay. The male patient, age is 55 years, and he has type 2 diabetes mellitus and hypertension. He has no cardiovascular disease. His lipid panel is LDL is 110 mg per dl, and triglyceride level is 195 mg per dl, and HDL level is 46 mg per dl. So just find out the patient at which risk and what can be the targeted LDL level. Yeah, the patient is, got it. Means the patient has all the comorbidities except cardiovascular disease. So the patient at high risk, not moderate or not very high. It's said to be like high risk. It's not considered as a very high too. So it's a high risk. So that our target is to reduce up to 70 mg per dl. Yeah, very high. This shows very high, but extremely high means it is like around very high and more high also. So this is we have to reduce it 70 mg per dl. And one more case, 49 years, sorry, 65 years, female, myocardial infarction 2 years ago, and she undergone with CABG, and she has diabetes mellitus. Her lipid panel is LDL level is 98, and triglyceride level is 121, and HDL level is 39. What will be the risk?
She is already in
No, just the patient came now, and she has all this comorbidity with the lipid panel. Don't think that she has medicines or anything. Just see the case and tell which risk she is and what is your goal with seeing the LDL level. Yeah, she is very high, and she has to reduce at least 55 mg per dl. Yeah, she is in extreme. Yeah. Thank you. When acetate will convert to malonic acid into the cholesterol by an enzyme HMG coenzyme A. When statins inhibit this HMG coenzyme A, the cholesterol level will get reduced. Conversion of malonic acid to the cholesterol will get reduced, so that energy will be reduced in the cell. The energy cholesterol and triglyceride is more to give energy and for protecting the cell surface, like it will give, for cell wall synthesis. When there is a decrease in the cholesterol, it wants to absorb from the blood. So what happens is, in the cell, the DNA will activate the mRNA, and in turn it will help it will act on the endoplasmic reticulum where the ribosomes are formed. So this ribosomes will give rise to the LDL receptor. This LDL receptor will generate more synthesis of LDL receptor on the surface of the cell. So what happens when there is a decrease in the cholesterol? There is a need of energy for the cell. They will absorb the LDL from the bloodstream, and it will bind to the LDL receptor more. So more and more the LDL receptor will produce, and it will attach on the surface of the cell, and it will absorbs lot of LDL. So this is how the LDL can be absorbed from the cells bloodstream into the cell, so that LDL will be reduced. This is how the statin works, particularly on the LDL mode. So when come to niacin, this is an adipose tissue, and this is a liver. In adipose tissue already it will be converted triglyceride to free fatty acid, right? So in free fatty acid, from triglyceride into free fatty acid, this free fatty acid will enters into the liver. It will directly not enter as a triglyceride. It will enter first as a free fatty acid, and then it will enters as a triglyceride, and then it will convert to VLDL, and like that IDL and LDL. So this niacin will inhibit here, so that the conversion of free fatty acid and entering into the liver will be reduced, so that the further process of LDL formation will be minimized. And if you come for phenofibrates, the phenofibrates act on the surface of the adipose tissue and the blood capillaries, where it is on the PPR alpha. Here will be the PPR alpha will be present, where phenofibrate will act here, so that it will increase the PPR alpha receptors, so that it will activate the apolipoprotein 2C. By that lipoprotein lipase enzyme activation also get more, so synthesis of this enzyme also increase, so that it will easily absorb most of the LDL and chylomicrons. By this we can reduce the cholesterol level and triglyceride also, because a triglyceride is a chylomicron which is rich in triglyceride. So highly, when triglyceride level is high, more than like 200, 300, they will give combination of statins with phenofibrates. Why? Because it will increase the absorption in the adipose tissue or any peripheral vascular tissue, so that the release in the concentration of the chylomicrons or VLDL will be reduced in the bloodstream, so that further process of cholesterol formation will be reduced.